Welcome to the Deep Dive. Today we're tackling a topic that's, well, let's just say it's incredibly high stakes in our daily practice. Airway evaluation and difficult airway management. And this isn't just theory, right? It's about those moments where quick thinking really truly changes outcomes.
Absolutely. And our goal here is basically to fast track you to the core stuff. We're pulling the absolute must-knows, the surprising bits, and the really practical takeaways from some key sources.
Okay.
We're talking the updated 2022 ASA guidelines, stat pearls, studies on Macocha, the buzz around post-US, point-of-care ultrasound, and a good look at the difficult airway trolley. It's all designed so you walk away with knowledge that's clear, easy to remember, and genuinely useful.
It's worth pointing out, these ASA guidelines aren't just from one corner of the world.
No, definitely not.
It's a big international group, wasn't it? Multiple societies involved. They looked at all the new studies, surveyed experts. It's a solid consensus.
Exactly. So what we're discussing has some serious weight behind it. These are robust recommendations.
Okay, so before we jump into the how-to, let's nail down the what. What exactly are we talking about when we say difficult airway? Because it feels like it could mean different things.
That's a great place to start. The ASA definition is actually quite comprehensive. It's not just about tricky intubation, though that's part of it.
Right.
It's any clinical situation where someone trained in anesthesia that's key anticipates or unexpectedly runs into difficulty.
Okay.
Difficulty with what? Well, face mask ventilation, doing the laryngoscopy itself, getting a supraglottic airway like an LMA to work, tracheal intubation, obviously, but also extubation, or even needing an invasive airway.
So it covers the whole process.
The whole process. And they get specific about inadequate ventilation. They give clear signs, no or low CO2 on the capnograph, chest not moving well, cyanosis, SATs dropping, or those hemodynamic changes you see with hypoxia or hypercarbia. So it gives us a really clear framework. It tells you when you've officially entered that difficult airway zone.
That makes sense. So let's talk anticipation. You often hear the best management happens before things go wrong.
Absolutely. Preemptive action.
So in that initial look, that evaluation, what are the key things you're scanning for? What flags a potential issue right from the start?
Yeah, you're spot on. That early assessment is critical. The guidelines like ASA and stat pearls, they break it down nicely.
Critical.
First up is risk assessment. You need to dig into the patient's history, their records, any history of difficult intubation before. That's huge. Distorted anatomy, snoring, OSA, diabetes. These are all big flags.
Right.
And demographics too, age, sex, BMI, weight, height. They can all play a role.
And then the physical exam.
Exactly. The physical exam, bedside stuff mainly, but sometimes more advanced things too.
Yeah.
We're looking at facial features, the jaw. Can they open their mouth wide enough? Like aiming for 4 centimeters, maybe 3-4 finger breaths.
Okay.
Can they jut their jaw forward? That's prognathism. And head and neck mobility, that's crucial for positioning, getting that sniffing position.
The 35 degrees flexion, 15 extension.
That's the one. Also checking for big upper teeth, a beard, doing the upper lip bite test, little things that add up.
And measurements. Malampati comes to mind.
Yes. Malampati is key. It's all about how much the tongue blocks your view of the pharynx. Higher score, more obstruction, potentially more difficulty.
Makes sense.
Then you've got other distances, thyromental, sternomental, the gap between the teeth, neck circumference. And like you hinted, sometimes advanced stuff like ultrasound, virtual scopes, even 3D printing can come into play now.
Wow. Now, you mentioned scores. In the ICU, things can be even trickier. I saw something about the Macocha score, specifically for ICU patients. How does that fit in?
Macocha. Yes, that's a really valuable tool specifically designed for predicting difficult intubation in the ICU setting. Critically ill patients are just different, higher risk.
Right.
And studies show it works. Patients who ended up being difficult intubations had significantly higher Macocha scores. Think average scores around 6 versus maybe 3.5 for easier ones.
So it's pretty predictive.
Yeah, good sensitivity, good specificity, around 75–80%. It basically helps you identify those high-risk ICU patients up front so you can prepare more intensely. It's about proactive management in that specific environment.
Okay, so we've maybe used a score like Macocha, we've identified potential risks. Now, preparation. What does being truly ready look like?
Yeah.
Especially equipment-wise. Tell me about this difficult airway trolley or DDAT.
Preparation is absolutely key. The ASA guidelines hammer this home, and there's great stuff written about the DAT. First, it's about people. You need skilled help either there or instantly available.
Not a solo mission.
Definitely not. Second, communication. Talk to the patient or their family. Explain the risks, the plan. Shared decision-making. It's vital.
Okay.
Third, oxygenation. Get them positioned well, get supplemental O2 on before you start anything, and keep it going throughout, even during extubation. The guidelines are really strong on this.
Right. Pre-oxygenation and continuous oxygenation.
And fourth, monitoring. Just basic ASA standards, non-negotiable.
Got it. Now, the trolley itself.
The DAT. Yeah, the beauty is its organization. It's usually set up logically, maybe mirroring an algorithm like the Difficult Airway Society's ABCD plans.
To reduce cognitive load.
Exactly. Logic, simplicity, standardization. When things are stressful, you know exactly where to look. On top, you might have cognitive aids, flow charts, maybe key phone numbers, ENT, ICU, and a stopwatch. Time is critical.
Okay, so what's in the drawers?
Right. Drawer 1 is typically Plan A intubation, your standard blades, Mac, Miller. But crucially, also alternative blades, especially videolaryngoscope blades like a CMAC D blade.
Videoscopes are key now, aren't they?
Huge. Often the first backup if direct look fails, sometimes even first line for RSIs. You'll also have various ETTs, stylets, medial forceps, and capnography gear. The gold standard for confirming placement has to be right there.
Makes sense. Drawer 2.
Drawer 2 is Plan B. Oxygenate via supraglottic airway. Focus here is usually on second-gen SADs, iGel, LMA Supreme, Pro Seal, different sizes. They tend to have better seals, maybe lower aspiration risk. And importantly, flexible intubating scopes, like video bronchoscopes. They're increasingly seen as essential for intubating through an SAD if needed. A rescue pathway.
Plan C.
Drawer 3, Plan C. Face mask ventilation, assorted masks, oral airways, nasal airways, maybe Sugammadex for rapid reversal if you used ROC.
And the last resort, drawer 4.
Drawer 4, Plan D, emergency invasive access. This is your phonak kit, front of neck access, scalpel, bougie, maybe a size 6.0 tube. Ready for that? Cannot intubate, cannot oxygenate, nightmare scenario.
Wow, that's comprehensive.
It is, but just having the trolley isn't enough, right? You and your team need to be familiar, trained, maybe run simulations. Proficiency is key.
Absolutely. Okay, so the critical moment. We've assessed, prepped. How do the strategies differ if we knew this was likely coming in anticipated difficult airway versus when it just suddenly happens unanticipated?
Good question. The approach needs structure for both. For an anticipated difficult airway, a major strategy is awake tracheal intubation.
Keeping the patient breathing spontaneously.
Exactly. Success rates are actually really high, like 88–100% in studies. Or you might plan for anesthetized intubation, but with very careful steps. Simple things help too, like the BURP maneuver, that backward, upward, rightward pressure on the larynx.
To improve the view.
Correct. Device-wise, again, videolaryngoscopes are huge here. Better views, higher success. Bougies, stylets, also very successful, 87–100%. Flexible scopes are another option. SGAs can work, 65–100% success, but you still have that small risk of desaturation, maybe 2–3% of cases, if the seal isn't perfect or it's misplaced.
And combination.
Oh yeah, often you end up using techniques together if one isn't quite enough. And if non-invasive fails, you have invasive options like retrograde wire intubation or phonocricothyrotomy.
Okay. Now, what if it's unanticipated? You're in the middle of it, and suddenly you can't intubate or ventilate well.
Right. The emergency scenario. First thing, call for help. Don't be a hero. Then maximize oxygenation and maybe grab a cognitive aid, that flow chart from the trolley.
Stay systematic under pressure.
Absolutely. You still cycle through your non-invasive options. Bougies and stylets show great success even in the ED, like 96%. Videolaryngoscopes, again, 92–100% success after a failed attempt. Flex scopes, maybe 78% rescue success. SGAs for rescue ventilation, up to 94% successful.
Key point seems to be limiting attempts, though.
Crucial, especially in kids. Maybe max 3 to 4 attempts. And always mask ventilate between tries. Prevent trauma, buy time, keep an eye on the clock and the SATs constantly.
And if all else fails, CICV.
The cannot intubate, cannot ventilate scenario. Then it's immediate F&O. Has to be done quickly by someone trained. It's the final safety net.
Okay, let's shift focus slightly. Pediatrics. Kids aren't just small adults, especially their airways. What are the unique challenges there?
That's such an important point. Physiologically, they're very different. Kids desaturate much faster, lower FRC functional residual capacity, and higher metabolic rate.
So less reserve.
Way less reserve. Irreversible hypoxic injury can happen frighteningly quickly. Urgency is magnified.
What about incidents? Is difficult airway more common?
Overall, difficult mask ventilation is maybe 0.15%, difficult intubation around 0.05%, but it jumps way up in certain groups. Infants under 1, maybe 0.6%. Kids with cleft lipolate. could be nearly 5%.
Wow.
And the big lessons, like from the UK's NAP4 project, were stark for pediatrics. Poor assessment, poor planning, and critically, failure to plan for failure.
So always have plan B, plan C.
Exactly. And don't just keep trying the same thing if it fails. Change your approach. Limit those attempts. It's about adaptability.
How does assessment differ in kids?
Well, Malampati works for older cooperative kids, but you're really looking hard for any facial or jaw issues, micrognathia, macroglossia checking, mouth opening, neck movement, and document everything.
And anesthetic technique.
The golden rule is maintain spontaneous ventilation until that airway is secure, if at all possible. Maybe an inhalational induction with Savo, or careful IV titration with propofol or ketamine if inhalation isn't practical.
What about the CICV situation in a small child? Phonae is harder.
Yeah. Much harder. The anatomy. Small, floppy trachea. The cricothyroid membrane is tiny and hard to find. So for infants and small children, surgical tracheostomy might actually be the preferred, safer approach compared to a cricothyrotomy, a really key difference.
That's vital to know. Okay, speaking of changing approaches and new tools, point-of-care ultrasound, POCUS, you mentioned it earlier. How is that changing the game in airway management?
POCUS is definitely a game changer in several ways. First, for pre-intubation assessment, it can spot things traditional exams might miss.
Like what?
Like quickly finding the cricothyroid membrane, especially in obese patients where feeling it is tough. Certain measurements on ultrasound, like neck, soft tissue thickness, or tongue thickness, actually correlate with difficult laryngoscopy. It's like getting a sneak peek beneath the skin.
Interesting. What else?
Huge application in confirming ETT placement. Now, waveform capnography is still the standard, right?
Right. Gold standard.
But it can be unreliable if cardiac output is really low, like in cardiac arrest. Ultrasound gives you excellent accuracy for spotting esophageal intubation almost instantly.
Without stopping compression.
Exactly. You can see the double track sign if it's in the esophagus, or you can confirm tracheal placement by seeing the tube in the trachea or seeing bilateral lung sliding. It's visual confirmation.
This is a good adjunct, especially in tricky situations.
Definitely. The AHA even includes tracheal ultrasound in their guidelines now for confirming placement. Practically, you use different probes, linear for shallow things, curvilinear for deeper stuff, different views. The main catch,
Operator dependent.
operator dependent, requires training and practice, and things like neck trauma or lots of subcutaneous air can limit the view, but the potential is enormous.
Okay, so we've used our skills, made POCUS, the DAT.
Yeah.
We've secured the airway. But we're not quite done, are we? What about confirmation, extubation, and follow-up?
Absolutely right. The job continues. For confirmation, as we said, capnography is primary. High success, 88-100%. But if there's any doubt, the guideline is crystal clear. Tube out, try to ventilate, or use another confirmation technique. Certainty is non-negotiable.
Good point. And extubating a difficult airway. That sounds stressful, too.
It needs its own plan. A pre-formulated strategy for extubation. Again, have skilled help ready. Assess if the patient is truly ready. Pick the right time, right place.
Any specific tools or techniques?
You might consider using an airway exchange catheter, an AEC, or leaving an SGA in temporarily. It gives you a conduit for rapid reintubation if needed.
Right.
But be aware of risks, like putting an AEC down the esophagus by mistake.
Right.
And sometimes you even weigh the risks and benefits of doing an elective track before extubating a really high-risk patient. And always keep that supplemental oxygen going throughout the extubation process.
And finally, after it's all done, follow-up.
Critically important. Follow-up care. Number one is counseling. Talk to the patient or their family. Explain what happened, why it was difficult, how you managed it, and what it means for their future anesthetic care.
Empowering the patient.
Totally. Then, meticulous documentation. Note the difficulty clearly in the record. This is a safety net for next time. And where possible, advise the patient about emergency notification services or medical alert bracelets.
Makes perfect sense, that full circle of care.
Exactly. So, yeah, we've covered a lot of ground. From that detailed assessment and getting your gear organized with something like the DEET, to the actual techniques, the rise of POCUS, those crucial pediatric differences, and having plans for both expected and unexpected trouble. It's a whole system.
So wrapping this up, what does this all really mean for you listening right now? I think this deep dive really highlights that difficult airway management isn't just about learning a procedure. It's more a mindset, isn't it?
I'd agree with that.
It's about constant readiness, smooth teamwork, and always having that plan B, plan C, planning for failure, essentially. That ability to anticipate, switch gears, act decisively under pressure. That's really the core of excellence here.
Well said.
So maybe think back. The last time you faced an airway challenge, expected or not, how could these guidelines, these tools like POCUS or a well-organized DAT, maybe change how you approach the next one, give you more confidence, more clarity? What's one new question you might ask during assessment, or maybe one technique you want to get more hands-on practice with after hearing all this? Something to mull over.